trident sign. So what we're gonna do is we're gonna put the gain up and we're gonna put the depth down. There we go, so stop. So this is QL, turn the gain up. So this is QL, this is psoas, this is erector spinae, okay? Is this caudal?
Yes.
So you can almost see some of these cluneal nerves coming out from 1, 2, and 3 that are gonna go over the crest. So these are actually the cluneal nerves coming in. So we'll go over that. But the trident sign, I see these transfer processes, and so we call that the trident sign. And then we're gonna paintbrush medially. We're not gonna slide medially. We're just gonna paintbrush medially. We're gonna go over this again tomorrow. But main thing is as we paintbrush medially, we're gonna get the nerve roots, and then we're gonna get the facet joints. And let's go to this stop. And now we still got a little, yeah. So we've got this tile roof of the facet joints that are here, and now we're gonna go paintbrush a little more, and then we should have the spinal canal. So we're gonna have the ligamentous flavum, and we're gonna have the dura, and you can see the spinal cord pulse. This is posterior longitudinal ligament, and so these are what we call the horse's heads. I got it. And so these are the horse's heads of the lamina, and then just paintbrush toward the spinous process so they see it. So the spinous processes are going to be here and here. So paintbrush back through the horse's heads, and now go to the tile roof, and then go to the nerve roots. And then go to the transverse processes. So the point is if you know, if you're probing straight down, you see the transverse processes. If you angle a little bit, you see the nerve roots. If you angle a little more, you see the facet joints. You angle a little more, you see the lamina. You angle a little more, you see the spinous processes. But you're not trying to go this way, because the spinous processes are all bony and they're gonna block you. So you're starting at the transverse processes, and you're paintbrushing toward the midline. You're not trying to slide toward the midline. So you're trying to paintbrush toward that. So, and while we're here, if you'll go up and show the 12th rib. I don't know if you can sit down at all, but they can't really see past you. I just see all these heads behind you, going like this. Okay, so let's find that 12th rib. So we see one, and we see a 12th rib. Now let's see a little more lumbar spine, a little more. And now let's just paintbrush toward the midline and find a transverse process. So there's a transverse process, right? And here's the 12th rib. Is this L1 or L2?
L2.
You're in faculty, be quiet. So now paintbrush a little more and you're gonna see L1. So the mistake is thinking that when you come off that, go back to rib, and you see a transverse process, you think that's L1 because you're trying to count. But reality is the L1 is much shorter. So just paintbrush toward the midline. And then there's L1, very short and small between the 12. And I think this is a super important area because the diaphragm and the subcostal nerves, the iliacal, they'll have the gastric obturators coming in, I mean, the cluneal nerves going out. I mean, this is a really common place for complaints, and most people can't help them at all. So let's think about that. And that puts me to like my interest in the last several years, like forever, that I could never figure out how to look for, and I finally figured it out in the last year, and that's the fact that where's the psoas minor? Psoas minor comes off of 1, T12 and 1, right? Major is going to come off from 2, 3, 4, and 5. Where's the psoas major go? It inserts onto your lesser trochanter, right? Where's the psoas minor insert? doesn't insert onto a bone. It inserts onto the iliopectial ligament. And the corona mortis, which is the artery that goes around it, they call it the mortis because if you poke a needle in it, they might bleed to death. But the fact is one needs to, I've been wondering for years where that psoas, how I could image that psoas insertion. Because there's this abdominal pain from that iliopsoas, where it's the pelvic floor of the iliopectineal line. So I'm just saying it out loud, so maybe tomorrow, you'll be ready to look for it, but just don't throw away the psoas minor as being a problem, because as men, we tend to have this psoas minor tension, and what happens when we get that tension? Then our iliinguinal is getting taut from the pelvic floor, and our cremasteric cord is going through the iliopectineal ligament and getting pulled on. So we get this, very deep ache and abdominal pain, and people are mistaking it for abdominal wall or hernia or that, when in fact it's inside, and it's more of that ligament that suspends the pelvis on the inside, where the psoas minor is going to insert, and the pectineus is going to come in, and the vas deferens is going to come out, and it's inside, it's in the abdominal wall. But that's one of the for the future for you guys. So now let's go with short axis on L3. Long axis, short axis on L3. That's long. Short axis. Short axis. Short axis on L3. Just put it right there. There you go. Okay. So now let's go with the spine's process in the midline. Okay. And then I want both facet joints to show. Okay. So now we're going to have the spinous process, and we're going to have facet joint, and then show the transverse process a little bit better. There. So now we're going to have this W, and the medial branch is going to be right here. And this is going to be the transverse process. This is mammillary process. This is the spinous process. And now what we're going to do is we're just going to go up one vertebra. You see the W? Medial branch is going to be here. This is going to be mammillary with the facet joint, and this will be ligamentous flavum here, and then interspinous ligament, supraspinous ligament, and now and then this is going to be psoas. Now, if he goes off that transverse process caudally, you can just go off of it. Now we're going to have the psoas, and we're going to have the body of the vertebra. So now you can go over to the side and show them the vertebra. So there. So you just rolled. So here's the vertebra, here's the psoas. Nerve root's coming out this way. Transverse process. Show them the transverse process. Just go up or down. Transverse process, mammillary process, spinous process. And now go off the transverse process. And then that's transverse process, go off of it. And now you can see the QL inserting, and you've got the psoas. You've got the nerve root coming out, and if you turn the Doppler on, you'll never want to put a needle there. But so put the Doppler on. Let's see what it looks like. We need help. So I want that radicular artery. There. Because this is the nerve root in there. So. If you'll put the transverse process in view again. There, hit freeze. Hit freeze. Hit freeze. Okay. So, and my point is here's the vertebral body. This is a sympathetic chain, and then he's on the right side. So this is vena cava on this side. But when Seth and I and Stan we're doing lumbar discs, we have to worry about something, because the QL's inserting here and psoas is inserting here, but the abdominal wall has a space, peri-abdominal space where you can actually get into the bowel. So when we're doing these discs procedures, what we're going to do is we might actually, you know, in my case, I would shift it over, but the point is the needle would almost hit the transverse process, and then I would move the probe slightly, and then it would slide down. I'd have to kind of make sure that when they tell me they feel in their big toe, that I move the needle a little bit, and then I drive it into their disc. So, unfreeze, and Doppler off, and then that transverse process again, sticking up. There it is. So here's where our disc is going to be. So as he slides off that transverse process, you're going to see that vertebra better. And go up or down one to see if it's any better to see. So this is actually better, right? That's there's the vena cava and the aorta, and then this and this. So a couple more clicks of depth, please. A lot more depth. More. Okay. So now you know what to do. Shoot for the disc. Now you see the other side, and you start to see the aorta pulse. So you're shining through the disc. Now go along axis and show them in long axis, the disc there, from straight lateral. And you're going to see the disc and the disc here, and a disc there, and actually you can see it almost shine through there to here. So you're shining through that disc there. So that's lumbar disc stuff. So I'm gonna. They're telling me to stop, but I want him to do the one most important thing that I do almost literally every day. I almost cannot not do it, and Stan just said it. But the fact is the L5 dorsal root ganglion that wraps around that L5 facet next to the high SI joint is probably, it's hard when you have a back person in front of you. I have a hard time thinking about not doing that because they've got facet joint arthropathy, they might have a disc, they might have some nerve root stuff, they got an SI joint, they got superior gluteal nerve problems, they got cluneal problems, they got all this stuff. But I got two discs. I got an extrusion at L4 and at L5. I mean, I got a little foot drop. I've got stuff on my right side. When you do the DRG on my right side or my left, that reproduces all of my radicular pain, and it also makes me better. So you got to realize that, you know, that L5 DRG, this dorsal root is going over the back of that facet joint, your sacroiliac joint, your sacrum. But that's one of the best ways to get to the ventral part of L5 as well. That's going to go down their leg, because you know anybody that does fluoroscopy knows that L5 is not that easy. L4 and 3 in an ultrasound is pretty easy, and fluoroscopy is pretty easy. L5, you got to bend the needle and you got to go down there. But you know, one of the best ways for us as sonographers is to realize that if we put 10 cc's on the dorsal root ganglion around the facet at L5, we're actually going to hydrodissect the whole nerve root, and we're going to get some great results on those people. So let's show us that. Oh, guess it was right there. Now it's gone. So this is a posterior longitudinal ligament, and this is the spinal canal. Spinous process. And now what we're going to do is we're going to go down to his high SI joint off of this side. Just go down. Keep going. So now that's pretty much sacrum. And you guys don't know it, but this is a foramen. That's S2. He's gonna slide up to S1. S1's gonna have to be at an angle this way. So go up to S1. So S1's gonna come out this way. And now as he goes up just a little bit more, all of a sudden the post-longitudinal ligament will show. And there it is. And then the dorsal root ganglion is going to be in this little sulcus right underneath the facet joint. So go up to the facet joint. So here's the facet joint, right? And then there's DRG. And this is a complex injection because you need to have the needle go here. You can't go from there. You got the iliac crest here, so you have to go steep using a curved probe and go down to here to the bottom and hydrodissect here. But once you start figuring this out, you're going to have to do that on every low back you've ever met. So, anything else, guys?
Most important shot here.
What?
Most important shot.
Yeah, that most important shot. So we'll go over it again. Okay. What do we do now?
So in the bottom any other question from our audience? 有人想要问题吗？如果没有的话，我们今天的课程差不多要结束了。没有人有问题吗？162发言。
Either we inject from the medial side to the canal. For L5, either we inject from the medial side and beneath the facet joint.
So, translate so that I can understand more.
Like interlaminar epidural.
你可以讲中文吗？
就是刚刚它是在 facet joint 的外面，要去 approach DRG。
是。
但是如果我们像打 L5S1 interlaminar epidural 的话，从中间去。
So his question is why we couldn't do from medial to lateral to treat the DRG of L5?
Excellent question. Turn the lights on. Okay. So guys, almost done. Don't let me lose you now. This is important. Okay, here we go. So here's the crest of the sacrum. Here's the sacrum. Here's the superior articular process of the sacrum, and then this is going to be the edge of the sacrum. So this is the joint. This will be the edge, and that's the sacroiliac, and then that's it, that's the iliac crest. And the nerve is here, and the mammillary process is up there with L5 and spinous process. And so the mammillary process is blocking you from getting to the nerve root. And so you can't get there from here. You have to come underneath to get to it. Because
需要翻译。
understand? Yeah.
You understand?
Because the facet is that's the facet joint, and there's this. And so what bone is that? That's the sacroiliac.
Yeah, you know.
So it's not the L5. It's the L5 nerve root coming out and going into that sulcus, and that's the sacroiliac joint right there. And so you can't get there because of the facet joint.
I mean, what if we puncture ligamentum flavor from medial side?
That's another question.
I believe he says in the same question, right? If we prefer interlaminar epidural instead of dorsal ramus.
He's trying to do the interlaminar epidural injection to get his L5.
So you're going, yeah, so he's going epidural.
Yeah.
So you're doing an epidural. You know, so we're dorsal root ganglion because you're trying to do a nerve root. And we're waiting till they come out.
And then also I
And
think
that's where the entrapment point is too.
yes.
Go.
Yeah，我们的经验呢是这边是 entrapment point，因为它那个 dorsal ramus 它跑出来以后呢，它向下走的时候呢，它会穿过那个一些 capsule 和 ligament 的一些 structure， 就好像你的 dorsal medial branch 的 entrapment 是它有一个 ligament cover 在它的 medial branch 的上面，所以你要把那个 ligament 把它整个再把它 lift up。你才可以把它那个 medial branch 整个做一个 hydro dissection。所以其实我们治疗这边，你就算治疗了它的那个 epidural， 它还是这边还是有 entrapment， 它还是会不舒服。
So to me, you know, because you've got caudals here, right? And then you got your coccyx, and we're trying to go in where the dorsal root is coming out, and the ventral root's going down. And instead of doing the spinal canal, and where you get the entrapment, maybe by stenosis or maybe a disc, but we're talking about the ligamentous, high SI joint, and there's intertransverse ligament and iliolumbar ligament entrapment, which I think is the most common of everybody. So, you know, if I was going to do if I'm thinking epidural, I'm not going to probably do a translaminar. I'm just going to go with the caudal and use a high volume and try and do it that way. And you do reproduce their L5 pain when you do that. So, but again, I'm not trying to block things. I'm trying to fix them. And the way to fix them is to use volume to hyperdissect. So, I guess we're done, huh?
Yeah, we're done.
We're done.
Yes.
Okay, well, thank you. See you in the morning. Yay.